Hey, good evening, everyone. It's 7 o'clock, so I think we can start with the introductions while we wait for some more people to join tonight. Thank you for joining on this very cold Wednesday. Today, we have the privilege to listen to Dr. Elne Conradie. Um, she is a professional chemist with a PhD in environmental science and management, currently specializing in biobanking and quality management. She's the quality assurance and biobank manager at the Northwest University Center for Human Metabolomics. Previously, she also worked as a compliance officer and HPLC technical signatory at a SANAS accredited pharmaceutical lab. She is passionate about rare disease advocacy, and she played a key role in establishing South Africa's first rare disease biobank in 2019 and continues to champion biobanking initiatives across Africa. Elected as ISPA's Director at Large for Europe, the Middle East and Africa in 2022, and again for the second term in 2025, she contributes to various ISPA communities and leads efforts to strengthen biobank networks and research visibility in unrepresented regions. She also helped establish the Medical Biorepositories of South Africa, MBERSA, and was appointed as DSI's Medical Biobank Cluster Coordinator in 2022, developing a business plan for a national biobank network. In 2025, she is leading the organization of a joint biobanking conference, or she led, sorry, that already happened, a biobank conference in South Africa in collaboration with ISPA, GGBN, MBERSA, BBSA, and SANBI. Through her leadership in ISPA, MBERSA, and the International Biobanking Initiative, Dr. Conradie remains committed to advancing biobank-driven research, fostering collaboration, and enhancing capacity-building efforts in Africa and beyond. Thank you very much, Elne, for taking time to do this presentation for us. I know it takes a lot of time to prepare and get ready for this. To the audience members, can I please ask that you just use the Q&A and chat functions for questions afterwards. You can also type your questions already during the talk, but we will get to the answering afterwards. And then please, after the presentation has ended, when you exit the presentation, you will get a pop-up asking you to answer a few questions. Please answer those questions. It will help us very much to improve these CPD events and to bring you the topics that you need. So tonight, Dr. Elne is going to tell us about a big initiative that she was part of the leading team, and it's called Improving Access to Rare Disease Diagnostics in Africa, Insights from a Multinational Pilot Study. Thank you, Elne. Good luck.
Thank you for the introduction, Ilse, and good evening, everyone. Thank you for joining us. Today, I would like to share the story of a project that began with a simple question. Can we improve access to rare disease diagnosis in Africa through education, collaboration, and innovative diagnostic approaches? What I present today is a story of a growing network of clinicians, scientists, patient advocates, and international partners who are working together to address one of the most neglected areas of healthcare in Africa. Like Ilse mentioned, the title for today's presentation is Improving Access to Rare Disease Diagnostics in Africa, Insights from a Multinational Pilot Study. The work represents a collaboration between the Center for Human Metabolomics at the Northwest University, a rare cause from FIMCA Medical, the International Gaucher Alliance, and a remarkable network of clinicians across the African continent. Please feel free to scan the QR code to the publication for more information. I've also included the QR code on numerous of the slides, so if you missed this one, you will definitely get an opportunity again. Over the next 45 minutes, I will share why this work matters, what we have achieved so far, and where we believe this initiative can go in the future. When we talk about rare diseases, many people immediately think of conditions that affect only a handful of individuals. However, while individual rare diseases may indeed be uncommon, collectively they are not rare at all. Globally, it is estimated that more than 300 million people live with a rare disease. Thousands of different rare diseases have been described, and together they represent a substantial healthcare burden. Yet rare diseases often remain invisible. In Africa, this invisibility is even more pronounced. Healthcare systems are understandably focused on major public health priorities such as HIV, tuberculosis, malaria, maternal health, and increasingly non-communicable diseases. As a result, rare diseases frequently fall outside policy priorities, healthcare planning, and funding allocations. For patients and families, this can mean years of uncertainty. It can mean repeated visits to healthcare facilities, multiple referrals, incorrect diagnosis, and in many cases, no diagnosis at all. One of the key messages I hope you take away today is this. Patients cannot benefit from treatment, support, or research opportunities if they are never diagnosed. So therefore, diagnosis is the critical first step. So why are rare diseases so often missed? The answer is not a lack of commitment from healthcare professionals. Rather, it is the result of a diagnostic gap. Many clinicians receive limited exposure to rare diseases during their training. As a result, these conditions may not immediately come to mind when evaluating a patient. If a disease is not suspected, testing is unlikely to be requested. And if testing is not requested, diagnosis is delayed or missed. And if diagnosis is delayed, opportunities for treatment and support may be lost. This creates a cycle. Limited awareness leads to limited suspicion. Limited suspicion leads to limited testing. Limited testing leads to misdiagnosis. And misdiagnosis reinforce the perception that these diseases are uncommon or absent. Breaking that cycle requires intervention at multiple levels. But where do we start? The answer to the starting point emerged during a Building Capacity in Africa initiative that was initiated by FIMCA Medical. In 2021, an advisory board was established that brought together clinicians, lab scientists, patient representatives, and international experts. Participants represented multiple countries and healthcare systems. We asked a very simple question: what are the biggest barriers to diagnosis and rare diseases in Africa? The responses were remarkably constant. Again and again, participants identified one central challenge: education. Education at all levels. Education for clinicians, for healthcare workers, for patients and families, for policymakers and funders. Participants also highlighted the need for stronger referral pathways, better availability and awareness of resources, improved diagnostic access, and ongoing support after training. These conversations helped us to shape and design the initial pilot program. Instead of beginning with technology, we chose to begin with people. Instead of starting with laboratories, we started with education, because ultimately, diagnostics begin with a clinical suspicion. This slide captures the question that became the foundation of the project. What would happen if we trained clinicians? What would happen if we provided access to diagnostic testing? What would happen if we supported diagnosis across national borders? Would we see more diagnosis? Would we identify patients who had previously been overlooked? Would clinicians feel more confident to recognize rare diseases? And could we build a sustainable model that could be expanded across the continent? At the time, we did not know the answers, but we believed these questions were worth investigating. This belief ultimately led to the pilot study that I will describe today. To understand better where we are today, it is useful to understand the journey. Like I mentioned, the journey started off in 2021. The first milestone was achieved with the establishment of the advisory board. This was followed by an educational symposium that focused on the challenges of diagnosing rare diseases in Africa in the same year. The symposium attracted participants from numerous countries and generated significant interest. The discussion reinforced the need for practical solutions. As a result, in 2022, the pilot diagnostic program was launched. This program combined clinician education with access to diagnostic testing. Importantly, it was designed not only to identify patients, but also to test whether a cross-border diagnostic model could work within African healthcare context. The pilot generated valuable results and demonstrated feasibility. Building on that success, the network expanded further through a second training week in October 2025. Today, we stand at the beginning of a next phase of growth. What started as a pilot has evolved into a continental network. One of the reasons this project has been successful is the partnership model. No single organization could have achieved this alone. At the center is the Center for Human Metabolomics at Northwest University. The CHM provides the specialized lab expertise and diagnostic capabilities. Working alongside CHM are Femca Medical through their rare course arm and the International Gaucher Alliance, both of whom has extensive expertise in rare disease education and advocacy. Equally important are the clinicians across Africa who help us to identify patients, collect samples, and to provide ongoing care. Patient organizations and families also play a vital role. Together, these stakeholders form a network rather than a hierarchy. Knowledge flows in multiple directions. Clinicians learn from experts, experts learn from clinicians, researchers learn from patients, and patients ultimately benefit from improved diagnostic pathways. This collaborative approach has been fundamental to everything that we have achieved. The project was designed with several objectives. The first and most important objective was education. We wanted to improve clinicians' ability to recognize patients who might have a rare disease. The second objective was to establish practical referral pathways. Recognition alone is not enough if clinicians do not know where to send samples or how to get the testing. The third objective was to enable cross-border diagnostics. Could samples be collected in one country and be transported safely and efficiently to another country for specialized analysis? The fourth objective was to improve diagnostic outcomes. Would education and access actually translate into diagnosis? And finally, we wanted to begin building a sustainable African network that could continue growing beyond the pilot phase. As you will see later in the presentation, these objectives have largely been achieved. The pilot program consisted of two interconnected components, namely training and diagnostics. The training component focused on building clinicians' knowledge and confidence, while the diagnostic component provides access to specialized testing for lysosomal storage disorders. These two components were intentionally linked. Training without access to testing would create a frustration, and testing without training would likely result in underutilization and suboptimal sample collections. By combining education and diagnostics, we hope to create a complete pathway from suspicion to diagnosis. This integrated model became one of the defining strengths of the program. The training program was delivered at the Center for Human Metabolomics. Clinicians participated in an intensive week of learning that focused on inherited metabolic diseases, as well as lysosomal storage disorders and when to suspect lysosomal storage disorders. The program combined lectures, practical discussions, diagnostic resources, and case studies. Most importantly, participants were not passive recipients of information. They were actively involved in solving diagnostic challenges and discussing real-world cases. This approach helped translate theoretical knowledge into practical clinical skills. The goal was not to simply teach facts. The goal was to change clinical behavior. The goal was to help clinicians to recognize patterns, to increase confidence in suspecting rare diseases, and ultimately to improve patient outcomes. As we move into the next section of the presentation, we will see how this training translated into real diagnostic activity, real diagnosis across multiple African countries. Now that we have discussed the training component, I want to turn our attention to the diagnostic component of the project. One of the earliest decisions we had to make was selecting a sample type that would be practical across multiple African countries. Traditional blood collection often requires specialized collection facilities, cold chain transport, and complex logistics. These requirements can be difficult to maintain, particularly when working across large geographical distances and in settings with limited infrastructure. For this reason, we selected dried blood spots or DBS cards. A DBS sample is collected from a simple finger or heel prick. Drops of blood are placed onto specialized filter papers and allowed to dry before transportation. This approach offers several advantages. It is inexpensive, it is relatively easy to collect, and it is less invasive than venous blood collection. Most importantly, it is far easier to transport across borders and over long distances. For our project, DBS cards allowed samples to move from multiple African countries to the Center for Human Metabolomics in South Africa while maintaining suitability for advanced biochemical and genetic testing. In many ways, DBS technology became the enabler that made this network possible. Without a practical sample collection strategy, the diagnostic component would have been far more difficult to implement. This slide illustrates the complete diagnostic pathway. Everything begins with the clinician. A clinician evaluates a patient and identifies clinical features that raise suspicion of a rare disease. A DBS sample is then collected. The sample is transported to South Africa, where it undergoes screening using the CHM6-plex LSD assay. If enzyme abnormalities are identified, additional confirmatory investigations are performed, including genetic testing. Results are then communicated back to the referring clinician. Importantly, the process does not end with diagnosis. Positive cases are discussed with clinicians to support ongoing patient management and follow-up. One of the strengths of this model is that it links clinical care, diagnostics, and ongoing support rather than viewing them as separate activities. The pathway is designed to be practical, scalable, and clinically meaningful. The initial pilot study included 8 countries across sub-Saharan Africa. These were Botswana, Ghana, Kenya, Mozambique, Nigeria, Sudan, Tanzania, and Uganda. Since then, 6 additional countries have also been onboarded, namely Namibia, Zimbabwe, Ethiopia, Rwanda, Democratic Republic of the Congo, and Zambia. These countries were deliberately selected to represent different regions of Africa and different healthcare environments. Some countries already have access to established path labs and path lab networks that's connected to South Africa. Others relied primarily on private courier services. This allowed us not to only assess the diagnostic outcomes, but also to evaluate the practical challenges associated with cross-border transport and logistics. What is particularly exciting is that these countries were not simply participants. They became active contributors to a growing network of clinicians with a shared interest in rare diseases. Each country brought unique expertise, challenges, and insights that helped strengthen the project as a whole. The following slides will go into more depth regarding the initial pilot stage. Please feel free, as I mentioned at the start of the talk, to scan the QR code to the publications for more information. Over a period of approximately 27 months, the project registered 56 patients. At a first glance, that number may seem modest. However, it is important to remember that we are dealing with rare diseases. Unlike studies that focus on common conditions such as diabetes or hypertension, we did not expect to recruit hundreds and thousands of participants. What is more important is the quality of the referrals. These were patients who had been carefully selected based on clinical features suggestive of lysosomal storage disorders. The median age of the participants was approximately 5 years, reflecting the fact that many of these conditions present during childhood. The recruitment process demonstrated that trained clinicians were actively applying the knowledge gained during the educational program. And most importantly, referrals translated into diagnosis. And as we will see in the next slides, the diagnostic yield was remarkably high. One of the questions we were interested in was whether clinicians would actually use the network after they received their training, and the answer was clearly yes. Referral activity was observed across multiple countries. Tanzania, Kenya, and Botswana generated the largest number of referrals. Several factors may have contributed to these differences. These include clinician engagement, local awareness, patient access to healthcare facilities, and logistical considerations. However, regardless of the absolute numbers, the key finding is that clinicians utilized the system. Training did not simply increase knowledge, it changed behavior. Clinicians began identifying patients, collecting samples, and engaging with the diagnostic pathway. This is an important lesson for future capacity building initiatives. Education is most valuable when it translates into action. In this project, we observed exactly that. This slide represents one of the most important outcomes of the pilot study. The model worked. Of the patients referred, we confirmed diagnosis for 12 Gaucher disease patients, 10 cases of mucopolysaccharidosis or MPS, and 1 case of Fabry disease. These numbers are particularly impressive when considering the context of rare diseases. The high diagnostic yield reflects the effectiveness of targeted clinician training. Clinicians were able to identify patients with characteristic clinical features and refer them appropriately. This finding demonstrated an important principle. Rare disease diagnosis does not always require large-scale population screening. Sometimes the most effective strategy is to empower people to recognize key clinical patterns and provide access to targeted testing. For funders and stakeholders, this is a particularly encouraging result because it suggests that relatively modest investments in training and diagnosis can have a significant impact. Gaucher disease emerged as the most frequent diagnosed condition in the study. 12 patients were diagnosed. Most referrals were triggered by classical clinical features. These included splenomegaly, hepatomegaly, anemia, growth failure, and failure to thrive. Many of these signs are not uncommon in African clinical practice. However, Gaucher disease is often not considered in the differential diagnosis. This again highlights the importance of education. The patients were always there. The difference was that clinicians had acquired the knowledge needed to recognize potential warning signs. Another important finding was the identification of previously described pathogenic variants. This provides confidence in the diagnostic approach while also contributing valuable information about disease patterns within African populations. For many of these patients and their families, diagnosis provided answers that had been unavailable for years. The second major category was MPS. 10 patients were diagnosed from the initial pilot project. Clinicians frequently referred patients based on characteristical features such as developmental delay, skeletal abnormalities, dysmorphic features, abnormal dentition, hearing impairment, and growth abnormalities. Again, these are patients who might otherwise have remained undiagnosed. One particularly interesting observation was that MPS2 was the most frequently diagnosed subtype. This resembles patterns that is reported in parts of the Eastern Hemisphere and differs somewhat to observations reported elsewhere in the world. Although the numbers remain relatively small, these findings suggest that African populations may have unique disease distributions that warrant further investigation. This highlights the importance of generating African data rather than relying exclusively on findings from European or North American populations. Beyond diagnosis, the project also generated valuable genetic information. All positive enzymatic findings were followed by genetic confirmation. Many of the identified variants had been reported previously in the scientific literature. This provides reassurance regarding the diagnostic accuracy. At the same time, the project contributes to the growing body of knowledge regarding rare disease genetics in African populations. Historically, African populations have been underrepresented in genomic research. As a result, our understanding of rare disease variation across the continent remain incomplete. Projects such as this help to address that gap. The value of genetic confirmation extends beyond the clinical patient. It informs family counseling. It supports further research, and it contributes a stronger evidence base for rare disease diagnostics in Africa. This is one reason why the network has implications far beyond the pilot study itself. Before moving on to lessons learned, I want to pause and reflect on what results mean for patients and families. It is easy to focus on the numbers: 12 Gaucher diagnoses, 10 MPS diagnoses, 1 Fabry diagnosis. But behind every diagnosis is a person. Behind every diagnosis is a family. For many families, receiving a diagnosis represents the end of a long and often frustrating journey. It provides an explanation for symptoms that may have puzzled clinicians for years. It enables more informed clinical management. It creates opportunities for genetic counseling. It may facilitate access to treatment programs or patient support organizations. And in some cases, it opens a door to participation in future research initiatives. When we talk about diagnostic yield, we are really talking about lives changed. This is perhaps the most important outcome of the entire project. The success of the pilot is not simply that diagnoses were made. It is that patients and family finally received answers. That is why this work matters. In the next section of the presentation, we will examine what we learned from the pilot, the challenges we occurred, and how these lessons are shaping the future expansion of the network. As we begin evaluating the outcomes of the pilot program, one of the questions we wanted to answer was whether cross-border diagnostics could realistically work in Africa. The answer, perhaps surprisingly before we started with this, is yes. Most samples reached the Center for Human Metabolomics within 1 to 2 weeks after collection. For countries connected to established path lab networks, transportation was generally reliable and efficient. Even more encouraging was the fact that DBS samples remained suitable for biochemical and genetic analysis despite traveling long distances across multiple borders. This finding is important because access to specialized labs remain limited across many African countries. And it is neither practical nor financially feasible for every country to establish advanced metabolic diagnostic facilities. Instead, we should focus on regional centers of excellence that can provide specialized testing while supporting clinicians across a broader network. The pilot demonstrates that this model is feasible. It also demonstrates that innovative sample collection methods can overcome many traditional logistical barriers. In many ways, the transportation system became an enabling factor rather than a limiting factor. When we reflect on the pilot program, several key strengths emerge. First is the clinician training. The high diagnostic yield strongly suggests that clinicians were able to recognize relevant clinical features and identify appropriate patients for testing. The second strength was the use of the DBS technology. DBS samples provide practical, robust, and suitable for cross-border transportation. Third, we benefited from strong lab expertise and establishing analytical workflows at the CHM. Fourth, the project was built on collaboration. Clinicians, lab scientists, patient organizations, and international partners all contributed to the success of the initiative. Finally, ongoing engagement with clinicians created a sense of community and shared purpose. Perhaps the most important lesson is that capacity building is not simply about technology. It is about relationships, about trust, and sustained collaboration. Those elements proved just as important as the lab testing itself. While the pilot was successful, it also highlighted important challenges. The most significant challenge involved sample quality. Even though the occurrence was significantly less compared to other lysosomal storage disease referrals without training in South Africa, we still saw several artifactual results from the samples that came in, particularly from regions with high humidity and elevated temperatures. Research has shown that environmental conditions can affect enzyme activity in DBS samples. This finding has practical implications for future phases of the project. Additional desiccants, humidity monitoring, and improved storage protocols will be incorporated into future sample collection kits. A second challenge involved referral gaps. Although some countries generated substantial referral activity, others submitted relatively few samples. This highlights the need for continued engagement and ongoing educational support. Third, logistical challenges remain. Political instability, courier disruptions, and import permit issues can all affect sample movement across borders. Finally, we recognize the need for more structured evaluation of training outcomes. Future training programs will include pre- and post-course assessments and longitudinal monitoring of referral activities. Importantly, these challenges do not represent failures. Rather, they provide valuable lessons that strengthen the next phase of development. One of the most important updates I would like to share today is that expansion is no longer a future aspiration. It has already happened. Following the success of the pilot program, a second training week was conducted from the 27th to the 31st of October 2025. This training program successfully onboarded clinicians from 6 additional African countries. These countries are Namibia, Zimbabwe, Ethiopia, Rwanda, DRC, and Zambia. As a result, the network has now expanded from 8 participating countries to 14. Importantly, diagnostic referrals from these newly onboarded countries are already underway. And while these results have not yet been published, they represent the next phase of network growth and capacity development. This is a significant milestone. Many pilot programs and projects demonstrate success but struggle to expand. Our network has already moved beyond proof of concept and into implementation at a larger scale. For stakeholders and funders, this is an important indicator of sustainability and momentum. What began as a pilot study has evolved into something much larger. It is now becoming a genuine international community of practice. Today, the network includes clinicians from 14 African countries. In addition, there's faculty members from South Africa, England, and Brazil contributing to expertise, mentorship, and training supports. And we're also very delighted to be welcoming participation from Sri Lanka, further expanding the international reach of the network. This diversity creates unique opportunities for shared learning. For example, a clinician in Botswana may encounter a challenging case and learn from a colleague in Kenya. A specialist in Brazil may share expertise that inform practice in Zambia. Researchers in South Africa may collaborate with clinicians in Ethiopia to better understand disease presentation in different populations. The examples are limitless. The exchange of knowledge is one of the most powerful outcomes of the initiative. We are not simply building diagnostic capacity. We are building a professional network that supports continuous learning and collaboration. As we look ahead, our vision becomes increasingly ambitious. Phase 3 aims to create sustainable diagnostic capacity across the network. We want to include even more clinicians and even more countries into the network. The aim is to ultimately have each country represented by up to 3 clinicians. These clinicians will not simply become learners, they will become champions. Champions who can train colleagues, champions who can advocate for rare disease awareness, champions who can improve referral pathways within their own healthcare systems. Supported by international faculty from South Africa, England, and Brazil, this model creates a multiplier effect. Every clinician trained has the potential to influence dozens of colleagues and hundreds of patients. This is how sustainable capacity is built, not through isolated interventions, but through empowering local leaders. Although diagnosis is the immediate goal, the true impact expands much further. Diagnosis is only the beginning. A patient receives a diagnosis. That diagnosis informs treatment and management. Improved management leads to better health outcomes and improved quality of life. At the same time, diagnostic programs generate valuable biological samples and clinical data. These resources can contribute to biobanking initiatives. Biobanks supports research. Research generates evidence, and evidence informs policy. And policy can ultimately improve healthcare systems. This creates a virtuous cycle. The impact of a single diagnosis extends far beyond the individual patient. It contributes to broader scientific understanding and healthcare improvement. This is why rare disease diagnostics should be viewed not only as a clinical service, but also as a strategic investment in research and health system development. One of the most exciting opportunities emerging from this work is the role of the CHM Biobank. The Biobank serves as a platform that connects diagnostics, research, training, and collaborations. For patients, it creates opportunities to contribute to future discoveries. For clinicians, it provides access to research partnerships. For researchers, it creates access to valuable samples and data. And for funders, it offers an opportunity to support infrastructure that generates long-term value. Africa contains the greatest genetic diversity on Earth, yet African populations remain underrepresented in many rare disease studies. By expanding diagnostic networks and biobanking activities, we have the opportunity to generate knowledge that benefits both African population as well as the global scientific community. The CHM Biobank therefore represents more than a storage facility. It represents a platform for innovation and discovery. When we think about the future, what does a successful project actually look like? Success is not measured only by the number of samples analyzed. And success means a larger and stronger network. Success means more countries participating, more clinicians trained and empowered, more patients that receive diagnosis. Success means that African data contributes to global knowledge. 5 years from now, we envision a network spanning at more than 14 African countries, potentially the entire continent. We envision hundreds of patients being screened. We envision stronger collaborations between clinicians, researchers, labs, and patient organizations. And we envision Africa playing a leading role in rare disease diagnosis and research. This is not simply an aspiration. The foundations are already in place, and the pilot program has showed us that this is possible. Throughout this presentation, I have shared evidence that this model works. We have demonstrated feasibility. We have demonstrated diagnostic yield. We have also demonstrated successful cross-border collaboration. And we have demonstrated the ability to expand the network. The question is no longer whether this approach can work. The question is how quickly can we scale it? Achieving that vision will require continued partnerships. It will require collaboration between clinicians, researchers, patient organizations, policymakers, and funders. Every additional clinician trait increases the diagnostic capacity. Every patient diagnosed strengthens the evidence base. Every country added to the network expands the reach. And today I invite you to join us in building Africa's rare disease diagnostic future, because together we can ensure that more patients receive answers, more families receive support, and more healthcare professionals have the tools they need to make a difference. As I conclude, I would like to acknowledge all of the individuals and the organizations who have contributed to this journey, the clinicians who participated in the training, the patients and their families who placed their trust in us, the International Gaucher Alliance, a rare cause from FIMCA Medical, the Center for Human Metabolomics, our international faculty and collaborators, and all the stakeholders who continue to support rare disease diagnosis in Africa. Most importantly, thank you to all of you for your interest, your engagement, and your commitment to improving patient care. I hope that today's presentation has demonstrated not only what has been achieved, but also what is possible when people come together around a shared vision. Thank you very much. And I'm